It's my great pleasure to be able to host Alex
Mariakakis.
Mariakakis. I've known Alex for 7 years and
Still never learned.
never know how to pronounce his last. Alex and I went a long time back. We are have a 1 year overlap doing a PhD at University of Washington, and we are technically academic cousins. Your advisor and my advisor share the same lab by the time they are PhD, so we are kind of close. Not that close, but pretty close. So great pleasure to have Alex here. Background, Alex is a professor in the Department of Computer Science at the University of Toronto. He runs the Computational Health and Interaction Lab. That's why he's here. Sort of across HCI, computer science, and AI and health applications. His research has won many awards, best paper from High Campus, numerous media outlets ranging from BBC to Toronto Cosmos magazines. I won't talk too much about your research because that's really contingent though. So take it from here.
Yeah, thanks. And thanks everyone. And hi everyone on Zoom. I'm going to talk a little bit slower than normal. I tend to get excited and talk quickly, but I will make sure that everyone on the video can hear me. So thanks for having me. Really excited to be here. I'm going to be talking about my work in the ubiquitous computing space. I think some of these topics and motivations are going to be very familiar to all of you, but I talk with different groups, so I'll make sure that we're kind of on the same page. So I like to start my talk with a very personal question just to make things spicy to start off. And that question is, when did you last see your doctor? We don't need to answer it out loud, but I just want you all to reflect for 30 seconds maybe. Was it recent? Was it for a medical emergency? Was it just a checkup? All of us have our own experiences, and it can be for many different reasons. To give you an example of what a timeline might look like, I'll put just a random example on the screen here. Maybe you are in a situation where you do have an annual checkup with your doctor. Maybe once a year between those events, you might have a situation like a foot break where you need to go to the emergency room and have something checked out. And the reason why I have this timeline here isn't to say that this is normal, this is good, this is not enough, but just to highlight the fact that there are gaps in this timeline. And in fact, I'll argue that there's two different kinds of gaps. The first one should come as no surprise. I put this on a timeline, so there's going to be gaps in time, right? There's going to be moments between these events when I don't really know everything that's going on with my health. So maybe I broke my foot and I want to know if things are feeling better. How do I know? I can feel it, but maybe I want to have that doctor's assurance so I could get some intermediate information. There's also another gap that isn't quite as obvious, which is the kinds of information I know about. If I break my foot, the doctor logically should not be checking my blood test results, my glucose levels, my heart condition. They're going to check my foot and then send me home and say your foot's okay, or wear this cast. And there you see all these examples here. If I'm going through a full workup, maybe I don't have that time or space to be able to ask about everything that's on my mind because of the constraints that exist. On that note, there are lots of constraints that exist in healthcare for why these gaps exist. I am from the US. I'm from North Carolina originally. I am in Canada now. I can't say that I'm equally an expert in both healthcare systems, but I think it suffices to say that there's all sorts of gaps in both systems. So unfortunately, I think this one will be familiar to many of you. There's obviously a cost issue in the United States where people can afford healthcare access are more likely to get it than those who can't. This actual number is probably stale. I should probably update it at some point, but you get the idea. Healthcare is expensive. In Canada, we do not have everything solved. I'll tell you that for sure. One of the big statistics you might read about is wait times. So as an anecdote, my wife wanted to go see a walk-in clinic physician because she doesn't have a primary care doctor because there's just taxed resources on that alone. So you sign up your name on a list. Maybe you're lucky and you'll see a doctor that day. Maybe you have to wait multiple days. And in this statistic here, even 7 days potentially, depending, of course, on the severity of the issue, the context that we're talking about. But I just want to be very clear. It's not like Canada is a magical land where everything has been solved. And even if somehow we could remove all of the barriers from patients and say, hey, patients, go to the doctor whenever you want and get your health checked. We don't want to do that. We have physician burnout, right? So a lot of physicians are seeing already too many patients, some of which obviously with valid concerns, maybe some people who just want to make sure everything's okay. So what happens if we close those gaps and say, hey, everyone, you can get your health checked every single day for every single concern? That's going to blow up our healthcare system. We're not designed for that. Nor am I going to argue that we're going to get there anytime soon or should, but a lot of different constraints at play. And there's other ones, geographic barriers, literacy barriers, more I could talk about, but that's just a few examples. And ultimately, what we're left with is a reactive inpatient healthcare system, right? We don't see the doctor until we really need them, whether it's a heart attack, whether it's foot break, whether it's an annual checkup, maybe in some cases, that's probably about as proactive as we're going to get. But what we would prefer to have is something that's proactive and outpatient. So rather than having to drag people in, putting them in hospital beds only when they have a severe issue, we want to identify these cases maybe in advance where they won't need as severe or costly care and try to be preventative about how we deliver healthcare. So what does my research do? My research tries to take advantage of ubiquitous technology. So these are things like smartphones, smartwatches, smart rings. I'll actually be talking about earbuds for my first project later today. So ubiquitous. And then I try to take advantage of the sensors that are on them. So I use the term sensor very broadly. It could be location, audio, motion. The touch screen can be considered a sensor, light, cameras, you name it. There's a lot of sensors on these devices. And it doesn't even have to be these devices. There are other devices that are all around us with one or multiple of these sensors. And then what we try to do is my group tries to consolidate this information into various kinds of health indicators. So these might be contextual indicators about people's mood or scalability or sociability. It might be their behavior. So I'm sure many of you are familiar with Fitbits that are doing physical activity and sleep tracking. And then also physiological data. So things like heart rate and cough rate. Some of these signals already exist. My group is also trying to come up with novel ways to generate these signals from unconventional sensors. Now, getting this data is great, but ultimately we want to put them together into something that's more meaningful. So often my work is situated in certain kinds of health outcomes or problem spaces. So respiratory diseases, aging, psychological well-being are just some of the many examples. Now, again, I'm probably preaching to the choir today, but I always have to make sure I have this caveat because I didn't the very first time I ever gave a talk. I'm not here to argue that technology is going to replace doctors. I'm not saying the smartwatch is going to take the place of your doctor and diagnose it, nor do I think it should. But of course, I'm thinking about how we can use these technologies to augment what they're doing. So while a lot of people, and myself included when I was doing my PhD, really think about digital health and these kinds of wearables from the notion of diagnostic screening, where we're trying to identify diseases early, that preventative care I mentioned. That's nice, and I'm not saying we shouldn't pursue that, but there's also a lot of other opportunities to use these sensors in healthcare without having to have this risk of maybe replacing a service that already exists. So, for example, if someone already knows that they have a medical condition, so they've already been diagnosed with heart failure, with COPD, or any of these chronic conditions, rather than having to bring people in for a regular check-in, what if we could deliver devices out to people and monitor their health over a period of time, and then encourage them to come into a hospital when something seems off to get the more rigorous test? And then also, not everything has to do with disease, right? So one of the last project I'm going to be talking about deals with menstrual health, and menstrual health by no means is a disease. More than half of the world experiences it at some point. So just trying to give people more information about their menstrual health and helping them be more familiar with what's happening to them, I think there's a lot of room for wearables in the space as well. Now, a lot of the work that I do is from the sensing perspective. How do we use these devices to get more information, build machine learning models, all that great stuff. But I would argue that human-centered design is extremely important in this process. And to motivate this, I love borrowing this example from Matthew Kay, who you didn't overlap with him, but he was at the University of Washington as well. And it's a bathroom scale or washroom scale for measuring your weight. This is a very ubiquitous sensor. How many people have one of these in their house? A fair number of people. It's a sensor. It gets us a measurement, right? And it's a very basic interface. You get one number, in this case, 2.5 maybe. Maybe you have an app that's connected, but not a super sophisticated one probably. Now, let's say I stood on the scale and I like to make up numbers for my weight. Let's say I stepped on it today and it said 200 pounds, not kilograms. And then the next day I step on it because I'm curious about my weight and it says 205. 5-pound difference between yesterday and today. Some of us would say, that's not really a trend. It's just, that's this accuracy of the sensor. That's maybe I drank too much. Maybe I wore extra clothing. Maybe I weighed myself at different times of day. Other people might look at that and say, oh my goodness, that's a 5-pound per day change. I have a linear trajectory. I need to radically change things. Obviously, that's an extreme reaction. But because we have such a simple interface, just a number without a lot of context, without a lot of guidance on how to interpret that number, we're kind of leaving people on their own to figure out what to do with that data. So what happens now if I start saying, hey, we're going to use earbuds and measure blood pressure? What happens if we're going to give you all this data to tell you more about your menstrual health? Or maybe you've seen examples of people building smartphone apps that can diagnose melanomas and tell whether they're cancerous or not. Yes, we can build these apps. I'm not saying we shouldn't do it and think carefully about it, but how are you going to give that information to people? Or should you be giving that information to them? Or to what extent should you be giving that information? Do you hide the results and say, talk to your doctor to get your app result for your skin cancer? Probably hard to convince people of that. So really thinking carefully about this is important. So with that, my group is the Computational Health and Interaction Lab, not named after chai like the tea, but it's a cool acronym that works out. And I've already explained that we use Ubicom technologies. My research is in three themes. The first is that I try to use ubiquitous technologies for what I like to call momentary health assessments. The idea that you pick up a device, you do something with it, right? You tap on the screen, you do a speech recording, for example, and get some sort of indicator of your health. We're also doing continuous health sensing. So this might be something more of you are familiar with, like the idea of collecting data throughout the day, maybe once daily, maybe continuous Fitbit data, for example, and then interpreting data or giving people access to that data so that they can interpret it for themselves. And then also that interactive design piece, thinking about how do we put all this in a wrapper that helps people understand their data or think carefully about to what extent it should be interpreted for them. So my ambitious goal is going to be to talk about kind of one in each theme, but really I'm going to highlight the extremes. I'm going to talk about one project that's a little bit more sensing heavy. I'm going to talk about one that's a little more design heavy. And then it's that confluence that I think is really exciting. So I'm going to talk about a third project in between. We'll try to do questions in between. Feel free to stop me because I will just keep on talking otherwise and it will get boring. Any questions so far? I wouldn't think so. Cool. All right. So the first project I might talk about, I already alluded to it. I'm going to tell you about earbuds and how you can actually use them as a sensor. So many of you are probably familiar with an app that looks like something on the left. This is taken from the Oura Ring, but you've probably seen something similar if you have a Fitbit or any sort of fitness tracker. And the reason why I have this up on the screen is to highlight the different measures that these devices currently provide. And if you're to compare them to what are clinically known as the four classic or major vital signs, which are temperature, heart rate, respiratory rate, and blood pressure, if you compare the thing on the right to the thing on the left, most of them overlap, but there's one that's missing, and that's blood pressure. Blood pressure, I would argue, is one of the holy grails that people are looking at recently for cardiac monitoring or these kinds of fitness trackers, because it's a classic vital sign that is applicable to many people regardless of any health condition they may have, but you don't really see it in any devices. That isn't to say that you can't get blood pressure measured at home, but it's not really supported by current technologies that we have. So I assume some people in the room might have a blood pressure cuff. Again, show of hands out of curiosity. Number of people, it definitely depends on age demographics and various things. Some of you, maybe you have parents that use them. They're ubiquitous, right? They're fairly inexpensive to get a blood pressure cuff, although it can be prohibitive for some individuals to get it. It's generally considered to be a gold standard, at least for at-home monitoring, right? You an inflatable cuff, it's measuring something that maps very directly to pressure. But it's not the kind of thing you're going to use all the time, right? You have to sit there. There's actually quite a procedure if you ever read through the manual. You have to sit, you have to have your arm rested horizontally at roughly shoulder height, and you need to not be doing anything, not talking. A lot of prerequisites, so you don't really get it done very often. With that in mind, there have been researchers that have been trying to use smartphones and even smartwatches to estimate blood pressure. You might even see not necessarily the consumer grade devices, but Omron is a company that has been trying to push a smartwatch that does blood pressure estimation. And these are designed to be more convenient, more continuous. The phone-based solutions might require a little more precise operation because you need to put the sensors at just the right spot to get a measurement. These technologies are great, and I think we're going to see many things coming from them in the coming years. But there's one limitation that I'm going to highlight, and that's the sensing principle of how these work. So this will be my last question, I think. How many of you are familiar with photoplethysmography, PPG? I love using that word. Okay, great. We're going to learn some quick biomedical stuff. So, if you want to show off something to your friends, that word is photoplethysmography, PPG for short. Basically, it's a light-based way of measuring blood flow in the body. So, if I were to take my phone, for example, not check my emails, but to turn on the flash, there we go. So it doesn't look any interesting. I'll hold it for the Zoom as well. So this is my flash. I can cover the flash right now with my finger. And again, this looks completely benign, right? My finger is glowing red. But if I were to hold my finger very still and measure how much light was getting reflected back to the camera, you would actually see that the amount of redness that's going back into the camera is changing subtly. Why is it changing? Well, because there's blood flow going in and out of my fingertip. That happens to correlate with my heart pumping because my heart is the thing that's moving the blood in and out of my fingertip. And that is the very short explanation of photoplethysmography for you. So that's what, if you have like a Fitbit that has, the green LED that you might have seen, and sometimes they'll have different wavelengths, they're shining light into your body at a peripheral site where it's easy to kind of get in contact with the blood flow, measuring how much comes back. There's going to be some sort of constant amount of light that is absorbed by the pigmentation of your skin tone, but the part that changes is roughly correlated with your blood flow. And because of this, and by the way, I'll mention for a little later on that this doesn't just give you information about the heart rate, but actually you can measure a continuous signal from it. And people have done all sorts of crazy things with the signal, like, for example, estimate blood pressure. It's not straightforward. It requires a lot of math, and really that math doesn't generalize. So there's a lot of people doing machine learning, but there's a lot of biomedical literature that says the shape of this curve, not just the fact you have peaks and valleys, is very important. Now, I already hinted at what the downside of this is. It's a light-based measurement. Some of the light gets absorbed by skin tone. So there's going to be a massive bias or confound associated with skin tone. A lot of people are trying to remedy this by coming up with corrective factors for people with different skin tones, or using different LEDs to be able to measure precisely what skin tone it's in contact with. But there's going to be a fundamental limitation. So there's a little background on that. But if you think about how your heart is assessed, usually when you go into a clinic, for example, you're probably more familiar with a stethoscope, right? You go to the doctor, they put the little thing on your chest and they listen to your heart and say, yeah, that sounds good. They aren't necessarily estimating blood pressure out of that directly, but it turns out that heart sounds have a lot of different information about, is your heartbeat regular? Are there weird valve movements happening and whatnot? So we kind of embarked on this research to say, can we get these signals in a more convenient way? And then take it a step further, can we get these sounds and use them to actually estimate blood pressure? Now, yes, we could build a cool stethoscope and guide people to position in the right place. There are groups that have done that. But it turns out that these heart sounds are not just isolated near the heart. And here's where we get to the cool part. These sounds propagate throughout the body. And in fact, these sounds can even go to your ear. Now, it might sound a little weird, but I want you to think about the last time you maybe went on a long run, or if you're me, you walk up a couple flights of stairs and you get tired very quickly. And think about that time where you said, oh my God, it feels like I can hear my heartbeat. It's not your heart traveling to your head or anything like that. What's happening is the heart is pumping. There's more activity. And eventually there's vessels near the ear canal, and those start dilating and moving things near the ear. And also, from some investigative work we've done, there's also some direct sound transduction. So the fact that the heart is just generating a sound on its own, the sound doesn't just stay put in the heart, it does travel through the body. So there's a composition of these two phenomena going on. So I've convinced you that ear sounds can make their way up to the heart, but it turns out that you can actually detect them. I keep on taking these out today. You can detect these sounds using earbuds. Why is that? One more working principle thing here. A lot of the earbuds that we have today have actually two microphones for active noise cancellation. There's one microphone that's kind of directed outward from the ear that's designed to measure the ambient sound, the thing that we don't want to listen to, right? The TV in the background, the subway or whatever. It turns out there's a second microphone that's directed in towards the ear. And this is providing that feedback loop. What it's doing is that the earbuds are playing some anti-noise, or basically the opposite of what it's hearing on the outside, canceling and making sure that whatever the resulting signal is inside the ear works perfectly for the environment, for my ear shape, for whatever I'm listening to, all at the same time. So it's this internal microphone that we can actually leverage, not with an API. It takes a little bit of work to access this audio, and I could talk about it later if you have questions. And Orson's even done some work on this, I know. So using this audio, we can detect heart sounds, and we can take those heart sounds and we can estimate blood pressure. So that's the whirlwind tour of how things work. So what have we actually done with this signal? So at first, what we tried to do, mimicking the digital stethoscope that I mentioned earlier, or any stethoscope, we tried to see if we could get the sounds that we were listening to from the earbud to sound like they were coming from a digital stethoscope. Not just by using signal like filtering or anything like that, just removing noise, but actually using a deep learning model to basically learn a transfer function that goes from what we're hearing in the ear to what you would ideally hear in the heart. Basically, we recorded the two signals at the same time and try to match the two. And this is also a good point for me to emphasize the fact that this earbud audio is subtle and it's messy. So it's not like you could just magically hear these sounds and do everything. There's a lot of work that needs to go with this audio. So if I set everything up correctly, we're going to hear some heart sounds. This first recording is a clean example from a digital stethoscope. I think it's coming from my laptop. If you didn't hear it, at least you could see it on the screen. Fairly nice little peaks that look like heartbeats at a fairly regular rate. Not a lot of stuff that's happening on the outside. Now you can already tell based on the next graph that the thing you're going to hear from the earbud is not going to be as clean, so I'll play that. Basic.
Stationary?
Person is stationary, yes. I'll say for all of these things that people are going to be stationary. It does work with some moderate noise in the background, but movement is a whole other beast that we're looking at. So even then, it's very hard to hear. I promise there's at least like you could see a couple of peaks there, but it's a very noisy signal, right? So we built a model, we called it EarStethNet, that basically learns the mapping between these two signals recorded synchronously to try to turn the top into the middle into the top. And I'll play this example that came from our model. Again, probably hard for people in the room. It looks like a cleaner signal. The skeptics in the room will definitely say, oh, you're just filtering all the noise and you're just reconstructing the average heart sound. Definitely a concern that we have. We did do an analysis when we actually looked specifically at the heartbeat sound. So we say, ignore all the parts that could be noise. We don't care if we can reconstruct noise. Let's listen to the heart sound specifically and see if we're reconstructing those. And we did better than all these other techniques that exist. Still, we got a lot of questions when we published this. How do you know this is going to detect abnormal heart sounds if they don't appear in your data set? It's a good question. We didn't know that because we only had healthy individuals. A lot of other questions, and they all revolved around this working principle idea. What is actually happening with this signal? How do you know that it's detecting the actual heart sound, or is it detecting some sort of deformation in the ear canal, like I mentioned earlier? And we still don't have this answer. That's something I'm looking forward to trying to figure out in the coming year. But we did something that at least kind of got at this. We did a timing analysis with the data that we had collected. So we took our digital stethoscope audio as a reference to know when the heart sound started. And we took the earbud audio and we filtered it into two different frequencies, or basically two different kinds of sounds, high sounds and low sounds. And we took synchronous recordings and we kind of put them all in the same graph and tried to figure out when did the heartbeat arrive into the ear from the heart. And we tried to measure the time between this phenomenon. And then we asked this question, knowing the distance from the heart to the ear, do we see content in the earbud audio that corresponds to the speed of blank? So what is that blank? Well, is there anything that moves at the speed of sound in body, which, yes, people have reported that. It's 1.4 to 1.7 kilometers per second. So that's the ballpark we're looking for. Something basically moves very quick from the heart to the ear, then that's probably something moving at the speed of sound. But then we also said, is there significant information that's coming at a much slower rate due to the pulse wave velocity, which is basically the speed of the pulse moving through the arteries in different parts of the body? Depends on a lot of factors, lots of different things in all the different parts. but we're talking on the orders of meters per second rather than kilometers per second. And the long story short is that with this timing analysis, at least we're able to convince ourselves that there's both. There's something that moves at the speed of sound, and there's something that moves a lot slower. It's not entirely answering this question of what exactly is, the dominant part of the signal. I'm actually working on setting up a study where we're going to do scans of the anatomy around people's ears and see if we can actually see blood flow near the ear canal, which is going to be exciting. Doing a full biological model is extremely complicated when you think about what goes from here to here. Turns out there's a lot of different parts. But this was at least giving us some confidence that both different aspects of the signal were there, the pulse wave and the sound. Yeah.
Is the autoacoustic emissions that your ear makes themselves, that kind of like echo that your own ear makes, is that loud enough to be detected, and is that a source of noise?
There's a lot of sources of noise. Maybe the way I'll rephrase your question or to answer in a different way is that the seal of the ear canal is very important. There's a lot of factors. So if you have an earbud that's very loose and it doesn't have like a foam tip, for example, you can still hear the sound, but you're going to get a better quality signal when you have a nice seal. I've even seen some people put like earmuffs on top to really amplify the signal. People who are doing research in the space will sometimes have people take earbuds out and put them back in, and they'll get different signals, and they'll try to show it works. In terms of hearing like an echo, I mean, people have actually used that to their advantage for like ultrasonic interactions.
You test like babies' hearings.
Yeah.
Newborn ear screening.
Yeah. So there is actually Justin Chan at CMU has done some work at this, if I'm not mistaken. Actually, I'm talking with someone who's interested in tinnitus, which is ringing in the ear, to use these earbuds to detect. I could ramble. There's a lot of interesting stuff there, but this is a very noisy signal. I'm not going to say that everything is going to be clean for sure. So by going through this, it was a very small paper. It was like a workshop paper. Just wanted to basically we did this because reviewers told us we should, and we were really curious. But I was glad we did because we saw something really interesting. So I'm not going to go through all the 4 different rows, but we took this earbud signal that we did from this study, and when I say we, my student, compared this to a couple of other waveforms that he had been looking at from this dataset collection. And he came to me one day while we were having coffee. He said, "Alex, these all look the same." And it wasn't just him going crazy. Like it's peaks aligning with peaks, it's valleys aligning with valleys. And it wasn't necessarily the signals directly. It was actually when you take the second derivative of a lot of these signals. So it turns out that this low-pass filtered audio that we generate from that previous experiment looks like the acceleration of, let's say, the light-based measurement, that PPG I mentioned earlier. We also had something that was measuring the pulse wave for more accurate blood pressure estimation beyond just using a cuff. That looked similar. Even if we took the light-based measurement and put it right next to the ear, there's some similarities there. So I say this is in submission, but I actually heard it got accepted a couple of days ago, which I'm really happy about. We did a system called Arterial, where we took this earbud audio, and very similar to the last paper, first paper I mentioned, we did a reconstruction algorithm using some deep learning and some integrals. Integrals do come in handy after calculus, by the way. We took this signal, we did reconstruction to make it look like the acceleration of the pulse wave or some other signal that we had recorded, do the double integral, then do another reconstruction, a lot of deep learning and signal processing to say that, hey, you know what? We can get this signal from the earbud to look like the signal you would get from a PPG or a pulse, more direct pulse wave measurement. So here's some examples of what we got. So on the top, we have the light-based measurement, that PPG. The bottom is the double integral, or sorry, double derivative at that point, the acceleration of it. The colors might be hard to see, but green is what we're reconstructing from the earbud. The blue or gray is from the gold standard device from arterial pulse wave. And then the blue is a finger PPG. And even though those graphs are small, hopefully I can convince you they look pretty darn similar. Yes.
Is the audio figure, the first row, is the acceleration divided by 2 times, or it's the audio wave?
So the one on the top is just the audio wave. And we're saying this low pass filtered audio looks like the second derivative of these other signals.
Is there any kind of model explaining?
So when the paper comes out, it's really hard. We asked a lot of people who are experts in sound dynamics and sound production. how you do it. We found this one esoteric equation from a physics textbook that talks about what happens when a piston hits a baffle. A baffle is like a cylinder thing. There is something, but it's a very tough one to describe. We're left with a lot of people who are curious to learn more, but we have an equation that a set of equations that you can look at that potentially explain why it's a second derivative. Yeah. Now, of course, I said blood pressure. These are just waveforms. So something that we have been working on is taking the waveforms we've been getting from the earbud, throwing a lot of math, using all those cool little calculations you see there, throwing the machine learning. And then we have lots of punny names. So we call this one pulseer. We use this reconstructed waveform. We can actually use it for anything. We can use it for measuring heart rate. We can use it for cardiac output. In this case, we're using it for blood pressure estimation. And these are the results that we have so far. I feel fine showing them. So we have systolic and diastolic blood pressure measurements. And the key thing I'll emphasize here is that what we're getting from our system is comparable to if we took the same kind of methodology of using the light-based measurement, but the same mathematics, and applying it to different kinds of PPG sensors. Now, I'm not going to say that this is, the kind of device that could be used as a replacement for a blood pressure cuff. You usually want to be below 5 millimeters of mercury, and usually with a more diverse population that we have. But at the very least, we would argue, hey, this is looking similar to what you get using other approaches that are non-invasive, and we're excited to see that. So that's all I'm going to talk about with earbuds. Are there any questions before I go to the next one? Yeah.
Yeah, so kind of going back to what you mentioned, consulting. Questions and
Yeah.
Is there ever a process for like kind of reconciling if there's conflicting information on like how to about the mathematical derivation of things and how to like instruct that more like quantitative approach?
Yeah, and I should repeat the question for Zoom as well. Yeah, sorry, I just saw the response there. The question was in trying to figure out the mathematical underpinnings or the model that explains this, how do we basically reconcile if we got different opinions? And quite frankly, I've talked to a lot of otologists, I've talked to a lot of cardiologists, and it's such a weird thing that a lot of them just like they have no idea, like we can't even get pointed to the right direction. Like this one model that we found, it was my student hunted down someone who specializes in speakers and tried to figure out like, okay, what's the kind of analogy that you would use here? And that's why I mentioned I'm really excited to do this study where we figure out what the anatomical or what blood flow looks like near the ear. People have done that before, but they never asked it for this kind of question of like, what's generating these heart sounds? So I think once we put that together, that's where I'm hoping things get really interesting. And I can at least steer the conversation of like, okay, knowing that this is the cause, why do you think this is happening? Because even though we found some sort of mathematical physical model that explains something, I don't know if it's it's a simplification, right? We're assuming the sound is coming from a single source. It's coming this way, and we don't even know if that's true. But a lot of people have published without anything. So at least we think we're a step in the right direction. Anything else? Okay. So now let's take you to another extreme. Sorry for I don't have a great segue. I've never been able to figure one out. But let's say you're using your earbuds and it measures your blood pressure, and then you decide you go to the doctor, and the doctor needs to meet with you. That's the segue I have. I see there's a question in the chat. I'll answer it in the end if you don't mind, but I will get to it, I promise. So obviously a lot of us, many in the room, I assume also, are looking at using LLMs in healthcare in some capacity. And of course, I want to emphasize the fact that I think many of us don't want to use them to replace what's happening with clinicians already. And that goes to, with this point, the fact that patient-physician interactions are really at the core of healthcare. We don't want to modify those whatsoever, right? And in Canada, and the same thing in the US as well, it's a very strained relationship because patients are coming in, they're sick, they're worried, they want their needs attended to, and they need to disclose information in order to get the best care. But there's also these weird power dynamics, right? The doctor's going to judge me if I say something about my smoking habits or my drinking habits, or if they hear that I'm not exercising as much as I should. And I already mentioned from the clinician standpoint, they're dealing with long wait times. They have data entry demands. I haven't mentioned documentation burden. I'm sure this department will be very familiar with documentation burden, right? So there's a lot of constraints in making sure that this relationship stays as fruitful as possible. And one of the different specific parts of this communication that my group has been particularly interested in is something called pre-consultation. So before you go meet with a doctor for the consultation, there might be an intake process where you disclose some preliminary information. The idea is that if that information gets summarized and handed off to a clinician, then before you actually talk with the doctor, they know what they're getting into. They can plan their questioning accordingly. They know what they could skip. They can plan for what they need to prioritize, etc. And pre-consultation can happen a few different ways. The two biggest categories I would say are questionnaires. So maybe you've had to fill out a long survey. I know in Canada that happens a lot where you get sent to a computer and you need to type in your information. And there's intake nurses as well. I actually did this a few times as a kid where I had to go to a doctor and explain what I've been doing for the past year, if I've had any pains, and then the doctor was sent that information so that they knew exactly what was going on. Both are systems that are great, but they have their own drawbacks. Oh, the key thing I want to emphasize, good thing I put that note here. The great thing about this is that it's not for diagnosis. The role of the intake nurse or the questionnaire is not to make a decision. Pre-consultation is gathering information to hand off to a human, the trained professional who's making the decision. And I'm already going to steal my thunder a bit. That's why LLMs are so great here, because we don't need to worry about whether they're going to be right or wrong. They're just gathering data ahead of time. So what are these trade-offs I mentioned earlier? Well, questionnaires, they're scalable, right? We could deploy as many questionnaires as we want, not worry about using up resources. But boy, I hate filling out questionnaires. I don't want to type out everything, so I'm going to give very minimal information or skip things if I don't think they're relevant. Conversely, with intake nurses, very useful resource to have in a clinic, but they're a strained resource because they could also be doing other tasks that are needed at any given time. But they also get better answers because they can be friendly. They can have a back and forth conversation. They can get better information because they can ask follow-up questions that a questionnaire simply cannot. So what do? We try to get the best of both worlds and we throw an LLM into it, right? Now, it's not just a matter of throwing a single LLM. There's a lot of different actually interesting questions we can ask about this paradigm. So we have an LLM agent, but it's actually designed to do two different tasks, or you can almost consider it as two LLM agents if you want. So the way that we've set up everything is that we have a chatbot interface that, unsurprisingly, talks with the patient, gathers their information, but then that information needs to go to a physician. And we're not just going to hand the physician a long transcript that defeats the purpose of doing pre-consultation to save their time. So we have a summary interface where we take all that information, distill it into something that's manageable for them to read, to incorporate in their EMR, etc. And just by breaking out these two different roles, there's a lot of different questions that we can ask. So obviously we can figure out how should the chatbot behave? Should it be nice? Should it be empathetic? To what degree should it be empathetic? How should the summary be formatted? Should it just be prose? Should it be a table? Should it be something in between? There's also this notion of accuracy. How well is this working? Are we getting high quality information? And then ultimately, is this actually useful? Are people going to use this system to some benefit? I'm not going to be able to talk about any of these, all of these, so I'm just going to skip to the last three and cover these in some detail. But at the very least, I'll show you the scenario and paint the picture of how we evaluated our system. So we designed this for a walk-in clinic in Canada. So these are situations where patients don't have a medical history that's in the system in the clinic. The physicians don't know the patients in advance, and the patients can be coming in with anything: foot break, mental health, combination thereof, etc. Our prompt was set up into basically two halves. We have a set of instructions about how it should behave. These were actually informed from one of our previous papers looking at how doctors converse with patients through a text-only environment. And then the chatbot's goal is basically to get answers to these questions. We don't need to, have it figure out what the right questions are because we know what the questions are. As a note, we didn't build this using a health-specific LLM. We use GPT-4. If you want to ask a question, maybe towards the end at this rate, ask that one because a lot of interesting thoughts on why we went that route. So I'm skipping some details to get to this very interesting question that we are left with. How do we know that the chatbot's doing a good job of getting information from patients? How do you measure high quality information? Well, very naively, we could say more words is better, right? Word count, more words, more stuff to say. But I'm sure you all can imagine scenarios where that would break. If someone has a really complex case, you might actually be doing worse because people just say more things, but it doesn't mean we're getting the information we need. We can try to measure completeness of information, which sounds great in theory, but when you actually try to define what that looks like, it's not really clear what that denominator of completeness should be. What is actually relevant, we don't know until later, and sometimes the patient might think something is relevant, but the clinician doesn't. We can also look at satisfaction, right? So you could say at the end, was everyone happy with the interaction? But I'm sure you all can imagine too, that depends on a lot of factors. Was the person nice? Did they have their problem resolved? Was it everything done in a timely manner? A lot of things outside the control of the chatbot. So we needed to come up with something else. And the student who worked on this, Brenna, did some digging and she found something that was really interesting. There's this linguistic principle or framework called Grice's maxims. These are a set of rules that kind of define what an effective conversation looks like. And these maxims are, there's 4 of them. There's manner, quantity, quality, and relation. Rather than defining all 4 of them, I'm just going to say we made some slight tweaks to those 4 and just define the ones that we actually ended up using. There's clarity of, whether the response was ambiguous or not. There's depth, thinking about the detail that was provided. Informativeness, whether they actually added something to the conversation or just repeated something earlier. And then relevance. Did the person actually say that something that was relevant? So these rules existed way before LLMs. It was just a principle from linguistics to say, are people having meaningful conversations with one another? But this gave us a very objective way of actually grading or coding the transcripts that we were getting with the chatbot. So let me show you an example. This is a real conversation, but anonymized, obviously for various reasons. So the chatbot in one of our rounds of study said, are you currently taking any medications? This also includes over-the-counter medications and herbal medications. And the patient said, yes, the pill. So in our coding process, we would look at this and say, it's not really clear. We don't know what pill they're taking. It's not really deep because we don't know what pill they're taking, but it's informative. We learned something. They're taking a pill of some sort, and it's relevant because it's addressing the question at hand. So we're satisfying some of these metrics, but not really all of them. But overall, we would say this is not a satisfactory answer. So then our chatbot in this case was actually able to ask a follow-up question. Does this mean oral contraceptive pill? Now, this did not come out of thin air. This is a snippet of the conversation. There were some things earlier that led up to this part of the conversation. But the fact that this follow-up question already motivates one of the reasons that having a chatbot could be useful. If you have a survey, you just can't get to that point. In this case, the patient said yes. Now, while the word yes is not informative in itself, given the context of the question that was asked prior, we could say now we have a clear response, a deep one, informative, relevant, and we could say we have a satisfactory answer. So we use this approach on a lot of different transcripts from a lot of different patients and cases, and we compared 3 different study conditions. We had a static questionnaire, we had our chatbot, and then we had a human who was acting as a chatbot. It was a trained medical professional, so someone who actually does intake on a regular basis, but they were put behind the screen to type as if they were a chatbot. So people were blinded to whether it was a human or an LLM in this case. So some of the key findings I'll highlight here is that the dynamic agents, in this case, the human and the LLM, were better at soliciting satisfactory answers to new lines of questioning. So taking those original questions that I listed and rewording them ever so subtly or shuffling them or combining them together to get more satisfactory answers right off the bat. This is a table that shows it. It's not quite statistically significant because we have 13 questions and really you can break it down to all of the questions. Some of the questions are things like, have you had surgery? In which case I wouldn't expect any big differences. Whereas the questions at the beginning are more broad. What are you in for? How long have you been experiencing these symptoms? We tended to see stronger differences in those cases, but overall not statistically significant. The other finding is that we found that both of the dynamic agents, again, the human and the chatbot, were able to ask follow-up questions like I highlighted earlier to gather better information, although unsurprisingly, the wizard was better. So the LLM asked some follow-up questions that improved the amount of information that was gathered, but unsurprisingly, the humans were better. You can read the paper to see all of the different situations. I believe I have one example here that again highlights a very interesting case from the LLM. I'm not even very sure if I like this one. It kind of rubs me a little bit the wrong way. But I throw it up here just to give food for thought. The LM in this case asks, understood, do you have a personal or family history of mental health conditions? The person simply said yes, obviously leaving more room for information. So the LM said, could you please provide a bit more detail? Your privacy is respected, and this information helps us in providing complete care for you. I could say this is good. It's outlining what pre-consultation is about. The more information you give us, the better we can help you. But there's some things that feel a little icky, I must admit, right there. Of course, we had safety guards in the study protocol, but I put this out there as food for thought. And we see in this case that the LM did encourage a lot of information, right? The person said depression, anxiety, and bipolar disorder. Now, we still don't know exactly who. We don't know exactly how many or how long, but it was able to solicit more information. Yes.
Just a quick question.
Yeah.
Content approach here. How in depth? Because I feel like for a human consultation, there's like a level of knowledge about how much data to gather, how in depth to go to do this.
Yeah.
I don't know if you're going to get to that.
No, I'm not.
How was that structured for the DLM?
Yeah, I put this up here. I didn't read this in full detail. That's something we're still trying to figure out, I think, to some extent. We really tried to scope it into saying your job is to answer these questions and to ask follow-up questions that clarify these. So we definitely had cases where maybe someone mentioned a symptom that maybe seemed related or unrelated, and we saw that because of how we prompted, it tended to steer away and not ask a lot of follow-up questions about those cases. Another challenging situation we had is people kind of along those lines where they had multiple competing concerns and they were equally important, but the LLM would just prioritize one and go down that path and never revisit the original one. That was something common. I think we kind of, in this case, beat the prompt enough to make sure that we were so concerned about going into diagnosis that we kind of said, your job is to answer these questions and only these questions. But of course, as with a lot of research in the LLM prompting space, as LLMs change, the behaviors change. So we try to, when we do this research, we try to elicit these high level, things to consider. But if you run this with the latest and greatest, maybe they do get a little more aggressive. I don't know. Yes.
I have two questions.
Sure.
First one is, you mentioned that through the agents, we want to achieve the advantage of both questionnaires.
Yes.
And a human nurse. So in this case, is there a reason why we want the agent to talk like human instead of just give the patient, like a questionnaire and then generate follow-up questions?
Yeah, I mean, good question. I wouldn't necessarily say we wanted to talk exactly like humans, right? So we definitely had cases. I've seen many other papers that talk about this as well, where, some people come in thinking an LLM is going to be robotic. And then what they find is often the opposite, that it's almost overly empathetic. We had a lot of cases where the LLM said, "Oh, I'm sorry to hear that. How can we help you?" And he had to kind of like tone down that over empathy. Of course, some people want some empathy. Sometimes it goes too far. And that's not just with our context. I've seen it in a lot of different healthcare contexts. So you're right. And I think that's something we wrestle with a lot is, as a computer scientist, I definitely don't want to say clinicians are wrong. They're the gold standard. But it is an interesting thing to ask, is there something that could be improved? Because sometimes clinicians are overwhelmed with work and therefore they can't convey empathy. So the fact that someone's willing to listen, you do want to encourage some of that. Where exactly that line is balanced, I don't really know. And you had a second question?
Yes. So about how we measure the effectiveness of communication.
Yeah.
So the original criteria is just for human-human communication. In this case, if the goal is to have the agent to summarize something that that's useful by the physician, for example. In that case, I imagine the criteria would be very different because it would be between a machine and a human.
Yeah, interesting. So I will say I didn't have enough time to talk about the summary here. When we did that evaluation, we really focused on getting kind of as much information as possible in the transcript. And then one of the things, we actually just submitted a paper on this last week, so we'll see what happens. But that part of from going from the full transcript to the summary, there's a lot of different considerations. Some people want a lot of information, some people want not so much. Physicians want to see the summary, but also patients want to see the summary. And what do they want to see? Do they want to see what the physician sees, vice versa? So I think when we did the study at the time, we really thought about get as much information as possible in the transcript. And then if worse comes to worse, you can always go back and look at it. But I think you're right. If we were to think about the evaluation of kind of the downstream goal of getting a good summary, we might come up with different metrics. Saw a hand very quick. Yeah.
Going off you.
Yeah.
Have you considered measuring adherence to prompts? And also, do you feel like if you're running this in a user study and it's in the same instance, does it change over time?
Yes. Sorry, I should also be repeating the questions for Zoom people in case you didn't hear. So the first question was, I remember the second question was the instances, adherence to the prompts. Yeah. So the question was, did we measure how often the LLM went off the script? And I don't know to what degree I would say it depends on what the script is, right? Like follow-up questions, I would argue, are part of the script. We did do an analysis of like how often the LLMs ask follow-up questions as well as humans. And unsurprisingly, the vaguer questions tend to get more follow-ups, not really surprising. So we do have those insights in the paper. I wouldn't even think about what it means to go off the script. I don't think we had any cases where it went and just started asking random things, or we definitely didn't have any cases where it did any diagnosis or anything like that. Maybe we just got lucky. Maybe we just had the right prompt. I don't know. I will say we had a human in the loop that also kind of made sure everything was okay in the process. But I don't think we had any cases like that regardless. Sure. Yes.
They ever any randomness, or were they proper study subjects when they behaved?
Yes.
Ideal patients.
Yes. So the question was basically, how did we do this as a user study? And did people ever try to mess around with anything? And we did this in a real walk-in clinic with real patients. So we basically, when people came in, because it's a walk-in clinic, they're just kind of sitting there and have nothing better to do while they're waiting. So we said, hey, do you want to do this? And we'll actually give you a summary that will go to your doctor. So I don't think we had any of those cases because people were motivated to actually get better care. Yeah. I see one hand. I'll take this one hand and then I've got 6 minutes for the last part. But yeah, go ahead on Zoom.
Hi, yeah, thank you so much. So I put this in the chat already, but I'm very curious before we move on to the next one. So were there in this experiment, were there any patients who asked questions to clarify in response to the chatbot? And if so, how did the chatbot handle those? So like, for example, I was part of a vaccine trial and I had to do this like really lengthy medical history with the nurse. And I kept asking her all these clarifying questions, like how distant of family members should I include in my family health history? They asked about significant injuries and I was like, hey, does this cut on my knee count? And then she had to look at it and was like, actually, yeah, I do need to record that information. So I'm just kind of curious, how does the chatbot handle that? Because I still think that, I don't know, I'm slightly biased, but I think that in-person component is pretty important.
Sure. Yeah, no, I'm not going to disagree there. I can't remember off the top of my head, but we are touching on a very important topic of how people interpret the questions. Because like on the one hand, I would argue pre-consultation is not something that requires a lot of domain expertise. It's very basic. But yes, people can interpret these questions very differently. And what we ended up with was very diverse kinds of responses. So, for example, like how would you rate discomfort on a scale from 1 to 10? People interpret 1 to 10 very differently. So we had people give just numbers without any context. We also had people give a number and then a long explanation and then say, well, it's a 6 on a good day, 8 on a bad day, and this is only on Tuesdays and whatever. And in the end, what we have is that because we've structured this so much in the LLM, we basically have these question answer pairs. And because the way that we scope this is pretty limited and that you're designed to to collect this information, I guess from the LLM's perspective, there wasn't really a right or wrong response. If people did answer things in diverse ways, it just collected all the information. We gave it to a summary. Now, then the question is this response the kind of thing that the physician was looking for? That don't think we've looked at too closely because, again, different physicians have their own thing. So I totally agree with you. The interpretation of the questions is something that could probably be looked at a little bit more, but nothing's jumping out at me. Okay, I am going to continue. Oh, I will just very quickly say, if you want to play around with this, don't use too many of our AI credits, but you're welcome to a little bit. You can scan the QR code, and we also have a website. It's much better on mobile because on desktop because we built it for desktop. Play around with it if you're curious. Hopefully we don't break it or anything like that. But we put this out there just to see what people, get your thoughts. There's definitely a lot to be improved in terms of the summary structure that I didn't get to talk about on the right side. You can imagine, the personality, the icons, a lot of things are left for improvement, but just curious to hear your thoughts if you're interested. Waiting for the last photo. Cool. All right. I've saved myself a whopping 5 minutes for the last one. I will go through this a little bit quickly. I've talked about these two extremes. I want to talk about something at the intersection of these two areas, and that's where the menstrual health research is going to come in. Yeah, finally. So, menstrual health is a very important health topic. Again, preaching to the choir here. And many people even consider menstrual health a vital sign, right? I talked about the 4 classic vital signs, but over half the population menstruates at some point. That should count as a vital sign. But if you look at the literature, yes, there's a lot of menstrual health apps that are out there, but there's a lot of flaws with these. You can read tons of papers that talk about the kinds of visualizations they provide, the language that they use. And I'll probably blow through these. The first one is that it's not just about period tracking. There's a lot more to the menstrual cycle than just that singular event that happens every once in a while. So yes, people do want to plan for their future cycles, but they also want to know their symptom patterns, their health status, and just their education, like just what's going on with my body through a period of time. Now, you notice I put a star next to that third one, very important star, because a lot of people, especially in our studies, like to ask this question: is my menstrual cycle normal? Well, boy, there is no such thing as a normal menstrual cycle. And that brings me to my next challenge. There is no such thing as a typical menstrual cycle. So yes, you can do a study where you collect lots of data from people, and you could say on average on a population that you can get this nice little distribution of 29 days as a standard menstrual cycle length. But if you look at that same cohort and you look at what the variation looks like within an individual, the same individual can have a cycle that's 21 days long in one period of time, and then later have one that's 35 days. That's normal, or that's okay. There's also, even within individuals, so the 21 to 35 was across the entire population. Even within the same individual, variation in 7 days is not terribly common. So there's a lot of that combating that stigma or that assumption that everyone must be very consistent. So therefore, when a lot of these apps rely on basic information like self-reported menstruation dates, amount of bleeding, these kind of self-reported outcomes, how can you build in that nuance and get something that's super complicated? Not complicated, but not as easy to maybe predict. And even these baselines within individuals are going to be hard to generalize. So my student Blue has just recently graduated. Her thesis was on trying to develop a menstrual health tracker that is more accurate and insightful. And again, there's a lot of different questions that, yes, sorry, there's a question about slides. Okay, hopefully people are still seeing the slides. Seems like they're working. So there's a lot of different questions that we've asked about this. We've done some work looking at people's menstrual health literacy. How are they consuming information about their menstrual health? No longer is it just from school. There's TikTok, there's social media, there's Reddit, etc. How can we use sensor data to make these trackers more accurate and insightful? And then how can we help people deal with this data? Because I'm going to make this argument that, hey, more data is better, but it's never straightforward. How can we help people through this process in interpreting data? Not going to cover everything. So we did a very ambitious study over the course of 3 months and technically 6 months, where my students said, we want to collect lots of data. We collected self-report data from surveys about menstruation. We collected Fitbit data. We collected hormone data on a daily basis using a device called a Mira hormone analyzer. It's a consumer-grade device that you can buy normally for people seeking pregnancy, but you can use it for menstrual health as well. And we use glucose because we read papers about glucose being related to hormones, and we were curious, honesty. This is the protocol that we did. We had 50 participants. We did it for 3 months, which from a CS standpoint is amazing. From a menstrual health standpoint, not a lot. 3 months, roughly 2 to 5 cycles. This is what the protocol looks like. I'm going a little fast because I realize we're out of time. But I do want to mention, we released this data set a couple days ago or a week ago. If you're interested in this data, want to do some modeling, it is messy. Good luck. but I would love to work with you to figure out how to make use of this data. And I said 3 months, but we have some data with 6 months of participants, which might be a little more fruitful. It's a subset, but we do have some longitudinal data from people. So what have we done with this data? We've looked at trends in glucose related to the menstrual cycle. So we actually showed that glucose actually varies with the menstrual cycle. People have reported this in the past, but we're some of the first people to have fine-grained daily measurements for both glucose and hormone data. We did this with a statistical analysis. Basically, we get a nice curve. That's nice. But I do want to talk about what people's reception to this data was and why this was such a fun study to do. So we actually found that by giving people access to this data, that actually helped destigmatize menstrual health for some individuals. The story that really stuck with me was that there was one of our participants was raised by her father. The mother, for whatever reason, wasn't in the picture. And she felt really uncomfortable talking to her father about menstrual health because of stigma. But by participating in our study, she had access to all these other signals. They had conversations about the study. Hey, I'm tracking my mood. I'm tracking my health. I'm tracking my exercise. And when she started to tease apart why things were happening in her health, that gradually kind of got into a conversation about menstrual health and became kind of a on-ramp to have those kinds of conversations where normally it just seemed like a taboo topic that she didn't feel comfortable talking about. That being said, it's not like everything was solved by giving data to people. We had all sorts of weird situations where participants would find one another and compare data. Whether it made sense or not would be a different story. We have this very basic quote where some person said, I have 4 cycles during the study. 2 of them look similar, 2 of them look different. What do I do? So thinking about how do we show this data to individuals is important. We actually had people who came from the same region of the world. That we had a group of South Asian students who found each other, and they were all fasting at roughly the same time during the study. We didn't think about the calendar very well. And it was very interesting to hear the comparisons that they were making about their data. They assumed that because they were changing their diet, they would see changes in their data. They saw some things that lined up, some things that didn't. There's a lot of nebulousness of people want to compare data, whether we tell them it should be comparable or not, and how do we help with that? Again, we're far from that. This is not available to download yet, but we do have some app screenshots. We deployed an app where we try to get some people's feedback on different ways that we could present data. This is not showing any comparisons yet. There's still a lot of work to be done. If you're a data viz person, you could probably groan at what you're seeing here. But this is our first step where we gave people the ability to connect different sources of data with different facets of the menstrual cycle. We gave people the ability to overlay different signals. We're thinking about using LLMs or different adaptation technologies to figure out how you prioritize different graphs or generate graphs that could help people address their own goals. But I'll just leave these up here as kind of a closing thought of, if you have any thoughts about what we should do here, let me know. That's it. I'm way over time. I appreciate you. If you have any questions, there's my email, there's my lab website, and all the socials. Thank you.
Thanks very much for the great talk. And for the information, in the next hour from 2 to 3 on the room 101, we're gonna have 1 hour student meeting time. So if you want to talk more questions, research, deep discussions, Alex will be here. All right. So thank you everyone for attending the talk. We'll see each other probably next week for the second time. Thanks.
I'm looking at the Zoom. I'm going to see if I can answer the questions asynchronously real quick.
There will also be an online option for student meetings. So
okay, yeah. So people who are on Zoom, is it the same Zoom?
No, I'll log in over there. So it's a different link.
Okay. So people on Zoom, if you want to join the student meeting, if you are a student, then I'm happy to answer the question there. I'm sorry I went a little bit over. If not, feel free to shoot me an email. I'd be happy to answer questions over there as well.
Orson, how are you going to share the new Zoom link?
The Zoom link, I think, is in one of the Craig's send a follow-up email, and I will email the link again to all the attendees.
Cool. I'll hop on that. Thank you.
Cool.